Thank you very much. We'd now like to invite Professor James Cox to the podium. Professor Cox, of course, needs very little introduction. He has his own Wikipedia page and has been a cardiac surgeon at Washington University in St. Louis for many years. He's truly one of the pioneers of cardiac surgery, and he's going to tell us how he evolved the maze procedure all those years ago.
Thank you, Chris. Peter, I'm honored to be here and speak today. I would much rather discuss that last paper than to give the talk I'm going to give, but I'll nevertheless do what I've been asked. But again, I do appreciate very much your inviting me here. I was not sure for a while if I'd be here or not. But the discussion of the evolution of the maze procedure, of course, is one of my favorite topics, and I think that it's sometimes not appreciated that if you look at the surgical developments, the catheter developments, starting back, let's say, in the 1970s, the first arrhythmia operation was done in 1968 for the WPW syndrome. But the original procedures that were done to try to control AF in some way, in some fashion, were actually isolation procedures, and they began in 1973 with the HISP ablation, elective HISP ablation surgically. There was an open heart operation that Dr. Will Seeley did, who had also done the first WPW. And what that did, of course, is simply isolate the arrhythmia to the atria, protecting the ventricles, required a pacemaker, and so on. And I put wavy lines in here for atrial fib because that's sort of the concept most people had, including us, of what atrial fibrillation was at that time. The next significant development was to isolate the arrhythmia to the left atrium, and in doing so, removing the need for a pacemaker. So we did the so-called left atrial isolation procedure, which allowed the arrhythmia to be confined to the left atrium, and the remaining three chambers of the heart could then beat a normal sinus rhythm. About a year later, after we reported that procedure, about a year later, Mel Scheinman at UCSF developed what was called catheter fulguration for the HISP bundle to mimic what we'd been doing surgically. And so the surgical ablation of the HISP bundle went away pretty much at that time. Shortly after developing the right atrial isolation procedure, the left atrial isolation procedure, we developed a procedure to isolate the right atrium except for the sinus node and AV node. That was for right atrial automatic tachycardias. And in 1985, Gerard Guéridon combined the left atrial isolation procedure and the right atrial isolation procedure into what he called the corridor procedure. And that really confined it didn't stop the atrial fibrillation, but it confined it to the body of both atria and allowed the sinus node to drive the ventricular impulse. But all of those were isolation procedures, and that none of them were developed to specifically ablate the atrial fibrillation itself. The first attempt to actually ablate the atrial fibrillation was based on an erroneous idea. Actually, we'd been mapping atrial fibrillation for about 5, 6, 7 years at that time. And those maps, as do the maps today, the maps come with pretty colors and lines and so on, but they don't come with interpretations. And so we erroneously thought that atrial fibrillation was generally caused by two macro reentrant circuits, always located in the same place, that they were located around the orifices of the pulmonary veins and the left atrial appendage on the left, and around the SVC and IVC orifices on the right. And so by doing a transection procedure, placing an incision from the far right tricuspid valve between the SVC, across the septum, between the LA appendage and the pulmonary veins, that we could probably stop that. And it worked very well in the model. This is what that looks like, going from the right side of the tricuspid valve all the way across behind the SVC, down the septum, all the way across to the lateral mitral valve. It worked for about 5, 6 months, and then the guy developed, the first patient we did developed atrial fib again. So during that time, we were getting closer and closer to understanding what we thought was the basis for atrial fibrillation because of the mapping, primarily doing three-dimensional mapping in animals using 256 bipolar electrodes, and mapping patients who had the WPW syndrome but who also had atrial fibrillation using these form-fitting silastic plaques containing 156 electrodes and putting them on the surface of the heart. We subsequently developed a sponge electrode that we could map. We could put in through the right atrial appendage and map the septum as well. And in putting all that together, my mentor, John Boyno, in electrophysiology, and Rick Schuessler, who's still in St. Louis, and I developed our concept of what atrial fibrillation looked like. This was the first patient ever mapped with multi-electrodes in the atrium. And it's interesting to see that little reentrant circuit over underneath the pulmonary veins. But nevertheless, we did extensive mapping in a lot of patients. And what we looked for is something that was a common denominator for this type of EKG. Because remember, the diagnosis, or the term atrial fibrillation is really a clinical EKG diagnosis. And it's made on the basis of an electrogram that looks like this. This EKG, unfortunately, doesn't tell you necessarily what's going on specifically in the atrium. So we were looking for something that was a common denominator, and what we found the common denominator to be was two or more simultaneous macro-reentrant circuits in the atrium. These are called rotors now, and there's quite a bit of discussion about whether they're small or large. I maintain they're large, or else this operation would never have worked. Can't possibly work on a focal arrhythmia. But nevertheless, what we found was what Moritz Alessi and others had suggested, Gordon Moe had suggested as early as the early 1960s, and that was that, with a little bit of variation on Moe's, but it amounts to large macro-reentrant circuits. There can be two or more, but there have to be at least two simultaneously, and they can be anywhere in the atria on either side. One of the problems with some of the studies that Dr. Cowan just talked about, and even the recommendations that I have a problem with, is you're recommending left atrial catheter ablation versus left atrial surgical ablation, and neither is adequate. Because if you ignore the right side, you have a lot of failures, and that's, we can talk about that another time. But the idea was then, if these reentrant circuits are large, which they are, then we could put incisions close enough together to interrupt their ability to occur, to preclude their ability to occur. And if the atrium cannot develop macro reentry, then it can't fibrillate by definition, because that's what atrial fibrillation is. So we developed what we call the Maze procedure. It's now been called the Maze 1 procedure because there have been some others. But the basis of that procedure was we had mapped, and there had been reported, other people had mapped, both in animals and in patients, specific macro-reentrant circuits located in a lot of different places. These things don't stay in the same place very long. Sometimes they change 4 or 5 times a second. But the point is, there's not an infinite number of places where atrial macro-reentry can occur in the atria. And so the goal initially was to put the lesions in the atrium to stop this reentry from occurring in places where we knew that it occurred. And it worked very well. The second goal was to leave something behind that left the patient capable of having sinus rhythm. Obviously, bread loafing the atrium would stop the atrial fib, but you wouldn't have sinus rhythm afterwards. So what you wanted afterwards is a sinus rhythm that could originate from the region of the sinus node and activate all of the atrium except the pulmonary veins, which were isolated. And that's exactly where, that's why this particular pattern of lesions allowed that to occur. And if you look at it, and I'd drawn this out originally on in a square box, but if you look at it, you have sort of one entrance into the atrium for the impulse, that's the sinus node, and one exit, the AV node going down to the ventricles, and one true route between the two. That's the only place that impulse can go. And then as it goes along there on its way to the AV node from the SA node, it also sends off a lot of what we call blind alleys so that the rest of the atrium can be activated. So the entire atrium is activated from that sinus beat in about 140 milliseconds. Normal atrial activation takes about 110 milliseconds. So it was well in advance of the ventricular activation, and it gave us a nice sinus rhythm. So the reason, when I looked at it and said, we're building something here with one entrance, one exit, one true route between the two, and a lot of blind alleys, and that's why I called it the maze procedure. One of the things we didn't know at that time was about the atrial pacemaker complex. The site of origin of a normal sinus rhythm impulse depends on the rate of the atrial discharge, the sinus discharge. And we all commonly think that all sinus rhythm originates in the sinus node, and that's just not true. During normal rates, 60 to 100 more or less, they do mostly originate in this area, but in bradycardia, sinus bradycardia, they originate low. More importantly, in sinus tachycardia, all sinus tachycardia originates from a very small area just anterior to the junction of the SVC and the right atrium. This was described first by John Bueno in animals and then subsequently described in patients. So the sinus tachycardia, whether it's humerally or neurally mediated, always originates right here in this sinus tachycardia. Unfortunately, that was a problem because we had an incision right through that area with the maze 1. And we recognized it when patients started coming back and saying that they couldn't generate a chronotropic response to exercise over about 110. A lot of these people were marathon runners and so on. The second problem is that there's a structure called Bachmann's bundle that allows almost simultaneous activation of the top of the right and top of the left atria because of the orientation and thickness of the muscle fibers. Bachmann's bundle allows the impulse from the sinus node area to get to the top of the left atrium in about 40 milliseconds. Actually 2 or 3 of the incisions in the maze 1 cut right across that Bachmann's bundle. For example, you see 2 or 3 of the incisions here in the maze 1 procedure. What that did is it created a terrible intraatrial conduction delay, and it ended up with the left atrium activating at about the same time as the left ventricle in about 30% of the patients. And it appeared that the left atrium had no transport function, but in fact it was the interatrial conduction delay that was the problem. So we took that maze 1 procedure pattern that you see here and changed it, and we studied this over about a 2-year period before we did it in patients first. But the first thing we did is we moved that septal incision back so there's no longer any incision either across Bachmann's bundle or in the area of the sinus tachycardia area. That moved the septal incision from in front of the SVC to the middle of the SVC, and it ended up with 2 incisions coming into the SVC. In order to get exposure properly to the left side, we had to transect the SVC to get over there. So we had really a transected SVC with 2 incisions coming into it. Very difficult. I usually spent more time repairing the SVC than doing the rest of the operation. The other thing we had to do is put a counter lesion in to prevent reentry around the base of the right atrium, right atrial appendage. So we only did a few of these because they were just technically too difficult to do. Made some further corrections and did what ended up with a procedure called the maze 3 procedure, in which we moved that septal incision even further posterior. So now it's no longer in the mid area of the SVC, as you can see on the right, but it's posterior to the SVC. So we moved it from anterior to mid to posterior SVC, and then put the other lesions in as needed to stop the reentry. And that's the pattern that worked. All 3 of the patterns worked fine. The maze is not a maze procedure, it's a concept. And they all adhere to the concept of the maze pattern, and they all worked. But this one had essentially no electrophysiologic complications. And so it's the one that stuck around for a long time. During all those years, RF catheter ablation became available, and so RF catheter ablation of the His bundle is what the cardiologists were doing. with catheters. That took the place of the catheter fulguration. So that's where we stood in the early 90s. We had a surgical Maze 3 and an RF catheter ablation of the His bundle. In 1995, we converted this procedure to a minimally invasive Maze procedure through a small left thoracotomy. That required that we use cryo surgery, linear cryo lesions, to replace the cut and sew. From that point on, we never did another cut and sew Maze procedure. They're all the procedures were done with cryo probes. There was one incision, that's the left atriotomy. And then in 1998, Hasagir's paper came out, described the pulmonary vein triggers and the concept that pulmonary vein isolation would cure a lot of atrial fibrillation, particularly paroxysmal atrial fibrillation. And from that point on, everything changed. The first thing that changed was that there were lots and lots of new energy sources introduced at that time. And the second thing that changed was that everybody and his uncle decided they were going to do different lesion patterns. We can leave this out and we can leave that out and so on and so forth. This is bad algebra. If somebody gives you a formula that says x plus y equals 35, you can't possibly figure out what x is. The point being that my concern at that time, and it's a concern I have with some of the hybrid procedures being developed now, is that if you introduce new energy sources and you introduce new lesion patterns at the same time, you have two variables. And you're going to have failures in the future, and it's going to be impossible to determine the reason for the failure. Is it because you've used the new lesion patterns so the operation is inadequate, or is it because you've used new energy sources that don't work? The way it's worked out over the last 15 years is that the energy sources are usually blamed. I personally think that it's usually the lesion patterns that are incorrect, and that's the reason there have been so many failures, but whatever. These are the energy sources that were available prior to Hasagir's publication. We could do a cut and sew technique or use nitrous oxide cryosurgery. Following that paper, all these energy sources were introduced. And I personally think most of them are quite good energy sources. My concern, microwave energy has been pulled from the market. Laser energy was pulled from the market. HIFU has just been shelved by St. Jude a few years ago. And I maintain that none of those energy sources has ever been used to do a complete operation. So I think particularly HIFU is an excellent energy source. But whatever, we don't know why they failed. And so it was blamed on the energy sources. The other problem was new lesion patterns. Now, if I would have no idea how somebody could come up with this lower right lesion pattern and think that's going to cure anything. I mean, there's no physiologic basis whatsoever for doing that. This is the one in the middle here on the bottom is just another, it's just a larger isolation of the posterior left atrium. But these energy patterns were usually either incomplete. For example, we tried to use just pulmonary vein isolation techniques to treat non-paroxysmal atrial fibrillation, and it doesn't work. It shouldn't work. Shouldn't expect it to work. And then these other bizarre lesion patterns. So they were either incomplete or bizarre, all confined to the left atrium. No right atrial lesion patterns were used in any of these patients. That means you're going to have about a 15% failure rate if you include right atrial flutter and recurrent atrial fibrillation. You'll have at least a 15% failure rate. The other thing that was not done is that the coronary sinus ablation was completely ignored. And you simply can't stop conduction in most patients if they have conduction across the left atrial isthmus by putting a lesion in the myocardium. There are two pathways that impulse can go across the left atrial isthmus. One's in the myocardium and one's in the coronary sinus. So you have to ablate both, or else you might as well not ablate either one. So with no coronary sinus lesion, you have another 15% failure rate. And if you look at most surgical and catheter procedures, 70% more or less is where most people end up after, if they follow the patients for more than a year. So what happened after that in terms of the evolution of the Maze procedure is Ralph Damiano introduced the term Maze 4 procedure in 2002. It was called the Maze 4 because it was done with radiofrequency clamps and with with cryoprobes. And it was a significant advance forward because it made the operation much quicker than it had ever been before. However, some people, when we had used the classification, that is the designation of previous Roman numerals, it had always been because the lesion pattern had significantly changed. The lesion pattern was not significantly changed with the Maze 4, but the conduct of the operation and certainly the speed of the operation was. So it probably deserved another designation. But the clarification, just for clarification, this is the Maze 3 lesion pattern on the left and right side, and this is the Maze 4 lesion pattern, and they're exactly the same from an electrophysiologic standpoint. The only difference is with the Maze 3, you isolate you create a box of isolation around the pulmonary veins with just one large circle. With a Maze 4, you accomplish that same box, but you have to do so with first putting clamps and isolating the pulmonary veins as pairs, and then connecting with the roof and floor lesion. But that ends up giving you exactly the same electrophysiologic operation as the Maze 3. Despite the results of the two most recent long-term studies, and practically the only long-term studies for catheter ablation, is shown here. Michel Hasseguer, who's the father of catheter ablation, and Karl-Heinz Cook, who's one of the best catheter ablaters in the world in Hamburg, have published these papers in JACC in the last 2 years. And Hasseguer's results are shown with single catheter ablation. He had 29% success at 5 years. And with multiple catheter ablations, 63% at 5 years. And his patients, 63% of his patients had paroxysmal atrial fibrillation. Only 37% had non-paroxysmal AFib. Karl-Heinz Cook's patients were all long-standing persistent AFib. Single catheter ablation, 20% success at 5 years, 45% with multiple catheter ablation at 5 years. So I think it's a mistake to look at data at 1 year, whether it's surgical or catheter data, or probably even medical therapy, because it doesn't give you the true index of what's going on. What we know from these papers, which are excellent papers from excellent people, is that the results of single catheter ablation for atrial fibrillation in the best hands in the world are about 25% at 5 years and about 50% at 5 years for multiple catheter ablations. So sometimes these people had 3 or 4 ablations. Those are the results in the literature. They're not prospective randomized, but neither is jumping out of an airplane with and without a parachute. So I think that some of these data speak for themselves very well. Because of those results, there's been a recent interest in the development of hybrid maze procedures. Probably Mark Lemire, who's in the audience, has done as much or more than anybody has to promote this. This is a photograph of contemporary type hybrid procedures. My concern about the hybrids is that, unfortunately, I think sometimes they're based too much on personal biases of the surgeons and cardiologists in terms of approach and device used, as opposed to trying to fix the problem. But the results thus far at 1 year are quite good. The problem I'm worried about is that we're going to go through the same situation that we went through 15 years ago when we were developing surgical, after the 1998 paper, where you have about as many different lesion patterns and hybrid procedures as you have surgical teams doing them. And I think if we don't adhere to some principle that we know works and has been documented to work, that we're going to end up 10 years from now wondering why the results aren't any better than they are after you follow them for a while. I think this is what I think which should be done and can be done very easily through a thoracoscope. And we'll talk about this more this afternoon. This is just a suggested procedure for the initial surgical procedure. This is not a maze procedure. This is a partial procedure that can be done very well and very easily by most people who do thoracoscopic surgery. And then you can follow the patient later with a catheter ablation as needed, depending on the mapping. I think that we'll talk about the joint versus delayed procedures this afternoon as well. But in summary, I think the maze procedure has undergone some evolution from the standpoint of the devices that have been used and the patterns that have been used and so on. It's also undergone a dramatic evolution from the standpoint of the conduct of the operation now with the development of these hybrid procedures. And that we started out back in the early days with a median sternotomy and on pump, the cardiopulmonary bypass, transitioned through minimally invasive approaches through small thoracotomies in the right chest, still on pump, and that's still done quite often in a lot of centers, and now are entering the area of the hybrid maze procedure off pump. And so I think that's a major progression and in the right direction, not only from the lesion pattern development over the years, but also from the conduct of the operation over the years. Thank you.